Hello everyone, happy evening, a very good evening. I hope I'm audible and visible. A quick nod there. Let me see. Am I audible and visible, everyone here? Yes. Hello everyone, happy evening and welcome to the today's YouTube live session where we are discussing some very important topics from our short 150 session. So the topics that we have today are from the section of medicine and pathology. These are extremely high yield. So we have had a recent short 150 session at Hyderabad. We have the next upcoming in Delhi, which will be on 10th, 11th and 12th of July. So all the FMG students who are appearing for 30th of July exam plus the NEET PG students or the next students who are giving the mock should also be attending this session because we are going to discuss all the high yield topics from all 19 subjects in 3 days. So that is what will be our target. So everybody who has the book, the Magic Book 4.0, the short 150 book, you can annotate it there. And if I have Hyderabad students also here who were there in the offline class, a quick thumbs up from you all as well so that I know that all of you are also attending the session and making the best of it. Yes. So for the students who want to attend the Delhi offline, that is face-to-face short 150 class, the link is given for the details and registration in the description of this video, so you can check that out. Okay, so the first topic that we are discussing is vasculitis, which is extremely important. This is page number 66 in the book, right? So the students who have the book can annotate this as we discuss this topic. Right, so quickly let's go through it because we don't have much time before the exam, right? So this is going to be like the last minute revision, the most important points. Okay, so have a look at this images and tell me that what is this first image showing? What vasculitis is this one? What is this image showing basically? This is the thickening of the temporal artery here, and this is basically temporal arthritis. Okay, what is this? This is temporal arthritis, also called as giant cell arthritis. Okay, this is temporal arthritis or giant cell arthritis. And what is the most important clinical feature that will be given here is the history of jaw claudication. So this is in temporal arthritis or giant cell arthritis. There's gonna be the history of jaw claudication, pain while chewing. That is what will be there. Along with that, the patient can also have shoulder pain. Okay, along with that, the patient can also have shoulder pain. So, what is this patient at risk of developing what? This patient of temporal arthritis is at risk at developing which of the following complications? The patient is at risk of developing blindness as well. Okay, the patient is at risk of developing blindness as well because of the ischemic optic neuropathy. Okay, so that is what we should remember here. Okay, that is what we should remember here. Going on to the next one. What investigation is this one here? Let me see the live chat if I can see that. Okay, very good. So this investigation here is DSA. Okay, what is this investigation here? It's DSA where you see the black vessels. This is a DSA. And what are you seeing in the DSA is this is the kidney basically. This is the renal artery. And what do we see here is Look at this. Look at this appearance of the vessels here, the dot-like appearance in the vessels, which is suggestive of aneurysms. Okay, so basically, what are you seeing in this image is there are multiple intrarenal aneurysms, and where do you see this? This is seen in polyarthritis nodosa. Right, so the diagnosis here is polyarthritis nodosa, where you have multiple intrarenal aneurysms. Okay, intrarenal aneurysms is what we have. Again, the next one that we have here, this investigation again is a DSA, which is showing the black vessels. And what I'm seeing here is this is the arch of aorta, then becoming the descending aorta. Right, and look at the three branches from the arch of aorta, that is BCS, brachiocephalic, left common carotid and left subclavian. Look at the left subclavian artery diameter here. Look at the left subclavian diameter here. What is happening to the left subclavian? It is narrowing. Okay, there is narrowing of the left subclavian artery. Okay, so whenever you have large arteries, the aorta and its branches affected, the large artery, very good. That is Takayasu's arthritis. So because of the subclavian artery involvement, the pulse in that limb will be affected, and that is why this is also called as pulseless disease. Okay, this is also called as pulseless. Subclavian artery is the most common site there. Next one, what is this vasculitis here? Where you see this purpura-like lesions here, which is palpable purpura that you see here. This is Hinosh-Schonlin purpura. Okay, this is HSP. What deposits do you get in HSP? Hinosh-Schonlin purpura. What deposits do we get in HSP? It is IgA deposits. Okay, very, very important. Remember, there's going to be IgA deposits. The classical history here will be this history of palpable purpura, GI bleed or abdominal pain plus arthralgia. Okay, this is the history in HSP. So basically, the purpura here is not because of thrombocytopenia, it's because of the vasculitis, the immunologic phenomenon. So remember that the platelet counts are not to decrease here. The platelet counts are going to be normal here. Okay, very, very important. So you have the history of arthralgia, abdominal pain and palpable purpura. Very, very important. Very good, Neha. What type of hypersensitivity is HSP? It is type 3 hypersensitivity, basically where you have immune complex deposits. Okay, where you have immune complex deposits, it is type 3 hypersensitivity. Okay, the next one that we have here, what vasculitis is this one here? Where we have red, that is the strawberry tongue, again in the DSA. This is the coronary angiogram basically that we are seeing here, the coronary one. And what are we seeing here is, there is the aneurysm in the coronary artery. So strawberry tongue along with coronary aneurysm becomes the diagnosis of Kawasaki disease. So in pediatrics, HSP and Kawasaki disease, one question on either of this is very, very important for any exam, right? So look at this one, strawberry tongue along with fever, cervical lymph nodes, very, very important, along with coronary aneurysm. This is the diagnosis of Kawasaki's disease. Okay, this is Kawasaki. There is the risk of coronary aneurysm development, so we need to monitor for that, right? What is the treatment for Kawasaki's? IVIG is what we need to give here. Okay, IVIG is what we need to give here. Next one, can someone tell me what vasculitis is this one here now? What is this vasculitis here? Where you have this deformity of the nose along with the cavitatory lesions in the lung. What vasculitis is this one? Yes, this is Wagoners granulomatosis. Okay, this one here is Wagoners granulomatosis. And why Wagoners? Remember that for Wagoners, it is the upper respiratory tract plus the lower respiratory tract, that is the lungs, and the kidney that is affected. So the respiratory tract plus the renal system is affected here in Wagoners. So look at the last line here. Upper plus lower respiratory tract, that is the patient will have history of sinusitis, otitis media, and the cavitatory lung nodules. This is going to be history of Wagoners. And what antibody do we have a positive in Wagoners? Very, very important. Remember that it is C ANCA positive. Okay, it is C ANCA which is positive in Wagoners. Whenever you see C ANCA positive, you always have to think of Wagoners. And remember, along with that, the renal involvement, there can be history of hematuria also that can be given in the question. Right. So remember two things. When you have lung plus kidney involvement, hemoptysis with hematuria, what are the differentials that you think of? One is Wegener's granulomatosis and the other one is the Good-Pasteur syndrome. Okay, and the other one is the Good-Pasteur syndrome. In Wegener's, it is going to be C ANCA positive. In Good-Pasteur's, what is it going to be positive for? Good-Pasteur's is going to be anti-GBM antibodies positive. The glomerular basement membrane positive is what it is going to be. Okay, very, very important again. हाँ, चलो पूरा नहीं पढ़ाएंगे, काफी सारा पढ़ाएंगे. So all the important things, right, is what we are going to do here. What is going to be the answer to this one? Intrarenal aneurysms and which is associated with hepatitis B. Which vasculitis associated with hepatitis B? It is polyarthritis nodosa. Which vessel is spared in polyarthritis nodosa? Remember, pulmonary artery not involved. So the pulmonary artery is not involved. The pulmonary artery is spared in polyarthritis nodosa. Okay, that is what we need to know. Pulseless disease is Takayasu's disease. Okay, the pulseless disease is Takayasu's. Okay, so that was one topic here, vasculitis. Men's syndromes, autoantibodies is something that we have discussed in the offline class. Inheritance patterns, which is dominant, which is recessive. I've told you the story mnemonics to remember this. Trinucleotide anemia also we have done. CD markers, lymphoma also we have done. Right. This is something that we have not done. So let us try to look at this topic again. The nephritic and the nephrotic syndrome. Okay. The nephritic and the nephrotic syndrome. Thank you, Dreamer. Okay. So I know that this topic looks very confusing, but few things that you need to know here, basically to answer your questions in the exam, especially the FMG exam. Now, what is the major difference between a nephritic syndrome versus nephrotic syndrome? Okay, what is the major difference between the two? In nephritis, remember, nephritic syndrome has RBCs also present. There is hematuria which is present. There is hypertension which is present generally in a nephritic. Nephrotic can also have hypertension, but hematuria is in nephritic mode. In nephrotic syndrome, basically it is proteinuria which is predominant here. Right, proteinuria is the predominant symptom here in nephrotic syndrome. So with proteinuria, the patient will develop edema, right? So puffing of the eyes, whenever there's renal involvement, the edema, puffiness of the eyes is what we see. Okay, at least take a first basic pointer that we should know the difference in between the two. Now coming to the identification of the what kind of deposits, and if you get images like this, how do you differentiate the two? Okay, can someone tell me what is this first one here? Is it membranous? Is it membranoproliferative? Is it minimal change? Is it PSGN? Is it IgA? Is it Alpots? What is this one here? So this one here basically is post-streptococcal glomerulonephritis. Okay, what are we seeing here is PSGN. Now the thing to remember in post-streptococcal glomerulonephritis is there will be the history of streptococcal disease preceding, and after that around 2 to 3 weeks later is when the patient will have cola colored urine, right? That is what the history will mention. So either it could be pyoderma or the throat disease, and then the patient after 2 to 3 weeks has hematuria, right? So this is going to be PSGN, and because it is post-streptococcal, post-bacterial, there are going to be a lot of WBCs, inflammation that is going to happen. So look at the normal glomerulus and look at in PSGN. how the cellularity is so much. You can see so much cells there, while you don't see a lot of cells here. So proliferation with hypercellularity is what is the feature here in PSDN. There is increased cellularity. Next one, look at the electron microscopy. What are you seeing in electron microscopy? The lumpy, bumpy appearance, the subepithelial humps is what we see. So it is lumpy, bumpy, and the humps, subepithelial humps is what we see. So look at the P, P, and P. Okay, look at the PPP in PSDN. So PSDN has lumpy, bumpy, and the humps. Okay, the subepithelial humps, right? And this is what you see in immunofluorescence, the immunocomplex deposits, right? Granular deposits is what you will see here. Granular deposits is what you will see here because of the immune complex. Because it is immunocomplex deposits, what type of hypersensitivity is PSDN? Again, it is type 3 hypersensitivity, where the complement levels also decrease. Okay, where the complement levels also decrease. So remember, this is type 3 hypersensitivity, complement decreases. So after a sore throat, if you have a hematuria within 2 to 3 weeks, then it is PSGN. If you have hematuria like within 2 to 3 days, then what is going to be the diagnosis in that case? After 2 to 3 weeks, it is PSGN. After 2 to 3 days of the sore throat, if the patient has hematuria, then what is the diagnosis in that case? Yes, remember, this is very, very important. Then in that case, it is IgA nephropathy. Okay, in that case, the diagnosis becomes IgA nephropathy. Very good, Indu. That is IgA. Kaushik L. Potts may remember AL. There's going to be anterior lenticonus ka history. There's going to be SNHL. This history I did not give you. So when you have recurrent sore throat के बाद recurrent हमेशा hematuria हो रहा है, it is IgA nephropathy, basically which has IgA deposits. Okay. Going to the next one, what are you seeing in this image here? Look at this one. Okay, the crescent shape is what you are seeing here. The crescent shape is what you are seeing here. So basically this is crescents. Wherever you see crescents, right, it is also called Bergers disease. Very good. Ananya, that is Bergers. Crescent is basically RPGN, right? The rapidly proliferative glomerulonephritis, RPGN. So remember, these crescents is basically seen in RPGN. There are multiple causes of RPGN. There are types of RPGN that we have. Remember, it is the parietal cells which contribute to the formation of the crescent, not the visceral. It is the parietal cells. That is what we should remember at least. Next one. What do we have here? What appearance is shown here? What appearance is shown here? The spike and the dome pattern is what we are seeing here. Right. So where do you have the spike and dome pattern? Where do you have the spike and dome appearance? The spike and dome appearance basically is seen on the membrane. So remember, this is seen in membranous nephropathy. Okay, this is seen in membranous nephropathy. Adults with history of cancer, right? It is like the acquired form common in adults. So this is spike and dome pattern which is seen in membranous nephropathy. Okay. Next one. Look at this one. This is very, very important. In the immunofluorescence, if you see this linear immunofluorescence, if you see this linear pattern, not the granular pattern. So linear immunofluorescence is suggestive of, it's an antibody deposition. It is not immune complex deposition. Where do we see antibody? In Goodpasture syndrome. The what antibody we have? We said it is anti-GBM antibodies, right? So Goodpasture syndrome is what kind of hypersensitivity reaction? Goodpastures, because it is antibody is type 2 hypersensitivity reaction. Okay, it is type 2 hypersensitivity reaction, very, very important. Okay, this is Goodpastures. Linear immunofluorescence, extremely important. There will be history of hemoptysis with hematuria. Look at the next one. What appearance are we seeing here? So can you see this double line appearance here basically? Right, the double line appearance. Wherever you have this double line appearance, what is it called as? It is called as tram track appearance. Okay, it is called as tram track appearance. So in tram track appearance, where do you see the tram track? Tram track is two words. So which is the two words wala? Membranoproliferative. So remember, this is membranoproliferative glomerulonephritis, where you see the tram track appearance. So two words tram track, two words membranoproliferative. Okay. One important point about Goodpaster syndrome. What is the gene defective here? Which collagen is defective? It is called 4A3. Collagen type 4, alpha 3 chain, which is affected, call 4. Remember, call 4. 4 is present in the floor. What collagen do we have in the basement membrane? It is collagen type 4. So remember, this is collagen type 4, alpha 3. In alpods, it is collagen type 4, alpha 5. Call 4A5 is alpods, which has anterior lenticonus, SNHL along with the kidney involvement. Okay. Going to the next one, what is this? Where you see these hyaline kind of deposits that you are seeing here. Glomerulosclerosis, right? The hyaline deposits nodular. These are called as Kimmel-Still-Wilson lesions, which are KW lesions, which are seen with diabetes mellitus. Okay, so remember that the KW lesions are seen with diabetes mellitus. What drug do you give for diabetic nephropathy? It is ACE inhibitors when there is diabetic nephropathy. So hypertension with diabetes, we should give ACE inhibitors. Okay, these are KW lesions, diabetes. In which condition do you see the wire loop lesions? In which condition do you see wire loop lesions commonly? Remember, wire loop is seen in lupus nephritis. Okay, lupus nephritis is where you have wire loop lesions, which is basically a type of DPGN, diffuse proliferative glomerulonephritis. Right, so remember, wire loop lesions are seen in lupus. Okay, they are seen in lupus. That is SLE. Absolutely right, that is SLE. Okay. So that is your one topic here, the nephritic and the nephrotic syndrome. So which is very important again, right? Going on to the next topic here, that is infective endocarditis. Okay, that is infective endocarditis. So first look at the vegetations here. Yes, Fallow's effect, SLE. Look at the vegetations and identify the type of infective endocarditis 1, 2, 3, 4. The first one here and the third one here, which basically have the vegetations along the line of closure, right? Which has the vegetations along the line of closure. But what do you have? Okay, what do you have is these are relatively smaller. So warty vegetations is what they are called as. These are comparatively larger. So the two conditions where you have along the wall is basically rheumatic heart disease, and what is the second one? Merantic or non-bacterial thrombotic endocarditis, right? So it is rheumatic heart disease, or it is NBTE, also called as merantic type, which can come as associated with cancers as well. It's non-bacterial. Very good. In rheumatic, remember rheumatic is RT. It is warty lesions in rheumatic heart disease, comparatively larger in NBTE. Okay, comparatively larger in NBTE. Yes, very good. Logically thinking, when you have vegetations which are so large, which are going to the chordae tendineae also. The vegetations which are large going to the chordae tendineae, that means it is infection. Okay, that means that this is infective endocarditis. This is rheumatic endocarditis, this is non-bacterial thrombotic, and this is infective endocarditis. So remember that infection can spread everywhere. So the infection is the one which will go to the caudate tendinate. This is very, very important clue for infective endocarditis. They are large vegetations. They are friable vegetations. When I say they are friable, that means they will break and they will embolize. So you see a lot of features of embolism everywhere. There can be splenic infarct, there can be renal infarct that we can see with infective endocarditis. Okay, so remember that it is friable. Next one, the vegetations which are present on both the surface, upper surface also and the under surface also. So basically this is present on bilateral surface. Okay, so which is the endocarditis which is bilateral surface? Read bilateral BIL in the reverse form. It is LIB. So this is Liebman-Sachs endocarditis. And where do you see Liebman-Sachs endocarditis? Liebman-Sachs endocarditis, that is LSE, is seen in SLE. Okay, so remember that LSE is seen in SLE. Bilateral Liebman-Sachs is bilateral surface. Okay, LSE is SLE. What criteria, what is the name of the criteria that we use for diagnosis of infective endocarditis? Not the Jones criteria. Jones criteria is for rheumatic. Duke's criteria is for infective endocarditis. For which organism in the Duke's criteria does a single blood culture is also enough? Yes, tell me that. It is not Jones. Jones is for rheumatic. Duke's is for infective endocarditis. Single blood culture is for which organism? Single blood culture is for which organism? Yes, very good, Kaushik. Absolutely right. That is Coxella burnetii. Okay, Coxella burnetii, which causes what disease? Basically, which causes Q fever. So, if you get a question that which rickettsia can cause endocarditis, it is Coxella. Okay, it is Coxella. Which is the infective endocarditis with CA colon? What is the organism that you think of? When they give you that a patient of CA colon now develops infective endocarditis, what organism it is? This is Streptococcus bovis, now also called as Galolyticus. Okay, Streptococcus bovis or Galolyticus. Okay, so very, very important. CA colon, it is Streptococcus bovis or Galolyticus. Coming to some important images in infective endocarditis. What do you see in the fundus? Okay, what do you see in the fundus? So this is what you are seeing here. Basically, you have the red periphery and in the center it is pale. Red periphery and in the center it is pale. So basically, what we are seeing here कि यहाँ पे ऐसा होगा और बीच में ये pale होगा. This is what is called as rot spots. Okay, this is what is called as rot spots seen in the eye. Again, because of the infarct happening. The pale is the infarct, the surrounding is the hemorrhage. Okay, rot spots are seen in infective endocarditis. Is it specific for infective endocarditis? No, it can be seen with leukemia, vagera, other conditions also. What else are you seeing here? In the nails are these hemorrhages, which are called as splinter hemorrhages. Splinter hemorrhages in the nail bed. What is the difference between Osler's nodes and Janeway's lesions? Which of these is painful and which of this is painless? Out of Osler's and Janeway's, which is painful and which is painless? Yes? So remember that Osler's is painful, Janeway's is painless. Look at where the lesion is. Janeway's is in the palm and Osler's is in the finger pulp, right? Finger में basically होता है. So remember, Osler's में the patient says ouch, ouch. Osler's is ouch, ouch. So it is painful and it is on the finger. Janeway's, the patient says जाने दे, there is no pain. And it is in the palm. Okay, and it's in the palm. So Osler's is painful, Janeway's is not painful. Right? So remember, this was about infective endocarditis. Going to the next topic in our magic book, that is page number 72. Okay, this is page number 72. Amyloidosis. Okay, talking about the important points for amyloidosis. So in amyloidosis, what stain is shown here, which was asked in the recent AIIMS exam also. This is the Congo red stain, where you see the red color, right? Congo red stain is what we have. Along with Congo red, एक light microscopy और ये है. Where do you get the apple green birefringence? Not in the light microscopy. The birefringence is something that we talk about on polarizing microscopy. Okay, it is something that we talk about on polarizing microscopy. It gives this apple green birefringence. Look at this apple green. Look at this apple green birefringence in polarizing microscopy. Right. On crystallography, what appearance does it give? It gives the beta pleated appearance. Okay, beta pleated appearance on crystallography is what we get. Okay, and the next one, what is the other stain that we can use? We can also use thioflavin. Thioflavin T and thioflavin S is the other stain that we can use. When you see on HNE stain, the light microscopy, amyloid, is it intracellular eosinophilic, extracellular? Eosinophilic, intracellular. Basophilic, what is it? So remember that on HNE, basically amyloid deposits are extracellular. Okay, they are extracellular and eosinophilic. Okay, they are extracellular eosinophilic deposits. Very important. Okay, they are extracellular eosinophilic. Remember the E and the E. Amyloid is EE, extracellular eosinophilic. Let's see the type of the deposits that we have in amyloidosis. Primary amyloidosis is what deposit? Primary is AL. Okay, that is AL. Remember the L for the light chain, right? L for the light chain. Where do you have light chains problem? It is multiple myeloma, right? Multiple myeloma, plasma cell dysplasia. AL is primary amyloidosis. Okay, AL is primary amyloidosis. Next one that you have, secondary amyloidosis. Secondary is 2 and it is 2A. So the AA subtype is what you have in secondary amyloidosis, which is associated with chronic inflammatory disorders or familial Mediterranean fever as well. Okay, AA is 2. So remember, secondary is AA. Dialysis related, which was asked in the recent NEET PG exam as well. Dialysis related is amyloid kaunsa wala? Beta 2 microglobulin. Okay, it is beta 2 microglobulin that we have dialysis related. Alzheimer's. In Alzheimer's, basically it is the beta amyloid plaques that we talk about. So remember that it is A beta. Okay, it is A beta that we have in Alzheimer's. Okay, we talk about amyloid, beta amyloid. So it is A beta. Amyloid polyneuropathy is ATTR. The polyneuropathy is the ATTR. So imagine the neuropathy is affecting the limbs and affecting the toes. So imagine like the toes is the TT wala. So ATTR is what you have. The TTR is transthyretin. Okay, that is transthyretin is what we have here. It is transthyretin, ATTR, the mutated type or the normal variant. What is it? It is the mutated or the wild. Okay, the wild or the mutated form. ATTR is what you have in amyloid. The normal one is where you see normal. Normal matlab with aging wala. Senile wala is normal. The polyneuropathy is basically the mutated or the wild form. Okay. So at least this much for amyloidosis is what we should know. What are the various stains that are used? What appearance does it give? and what are the various types of amyloid proteins that occur, accumulate in the various disorders. Okay. Anybody remembers we had discussed in the short offline class कि Alzheimer's disease में कौन सा monoclonal antibody देते हैं? Let me see who remembers this. Monoclonal antibody in Alzheimer's disease. Yes, anybody remembers that? Monoclonal antibody in Alzheimer's. What monoclonal antibody? We had read the drugs in Alzheimer's. The Alzheimer's में acetylcholine low. So you increase the acetylcholine by giving the cholinergic wala, that is acetylcholinesterase inhibitor drugs. Shalini, denosumab कैसे होगा? When I say denosumab, right? Look at the word itself. The OS tells you that it is for the bones. It is used in the bones ka condition, that is osteoporosis. Very good. I see Sai Arvind answering here. Absolutely right. It is aducanumab. Aducanumab. Look at the word. The nu tells you NU that it is acting in something neuronal disorder related to the nervous system. Sayanthani Dinos tells you OS is the bone ka related. है ना? And what does Alzheimer's ADUC tells you? Alzheimer's disease underlying cause is what it is acting on. So basically the underlying cause is beta amyloid accumulation. This goes and bind there. So remember this is aducanumab. Alzheimer's disease underlying cause is acting. Okay, so that is aducanumab. Remember AD helps you to remember this is used in Alzheimer's disease. Okay, this is used in Alzheimer's disease. So that was about amyloidosis. So I think we have seen 4 topics so far. First one we started with vasculitis, then we saw the nephritic and the nephrotic syndrome, then infective endocarditis, and then we have amyloidosis. Coming to the next one, the next 2 topics for the day. This is page number 73 in your magic book. Okay. Saroj, thank you so much, Saroj, for those kind words. Messages like this is what helps us, stay motivated as well. Thank you so much, and all the best for your future journey as well. Thank you so much. Coming to immunodeficiency disorders, what is going to be the diagnosis for this one? There is a male child who has a history of recurrent infections, and there are no mature B cells. Very good, Chandani. This is BTK wala, that is Bruton's A gamma globulinemia. What is the diagnosis here? This is Bruton's A gamma globulinemia. Remember the BB, that Bruton's affects more in boys. Why? Because it is X-linked recessive. So it is also called as X-linked A gamma globulinemia. Because there are no mature B cells, that is why it is A gamma, because the B cells, plasma cells maturing, that is what will form the immunoglobulins. So A gamma globulinemia. Next one, what do you have here? Recurrent cold abscesses, that is non-inflamed abscesses is what you have. There are cold abscesses. There is eczema. So eczema, there is IgE which is high with eczema. Eosinophils are also high. What is this one? What is this one? This is hyper IgE syndrome. As the term itself says, it is increased serum IgE. So this is hyper IgE, which is also called as Job syndrome. Okay, which is also called as Job. So remember, this is hyper IgE. E for eczema, E for IgE, E for eosinophils increased. And remember, there will be history of recurrent cold abscesses there. Next one. Where do you have late separation of the umbilical cord? Again, there is no pus here, right? There are recurrent skin and mucosal infections. So what they give you in the question is the history of gingivitis which is given, skin infections which are given, But again, there is no pus here. FMG doctors, you can attend in the upcoming short class in Delhi, right, on 10, 11, 12. This is not right. This is LAD. Remember LAD. LAD has LAT, that is late separation of the umbilical cord. It is leukocyte adhesion deficiency. So the leukocytes are not adhering to the vessel wall. They are not going out, and that is why there is no pus. So remember that this has neutropenia or neutrophilia. What does it have? It has neutrophilia. Neutrophilia is present here because all the neutrophils are in the blood. They are not going out into the inflammatory sites, into the tissues. So remember, there is neutrophilia. Okay, and what is the defect here? At least we should know the beta-2 integrin defect. Beta integrin defect is what we have here. What CD marker? It is CD18. Remember, adhesion. Adhesion is 18. It is CD18, beta integrin. Next one that you have, recurrent infections and granulomas with catalase positive organisms. Granulomas is chronic granulomatous disease. Remember, it is catalase positive organism infections. We have seen in the short session which is the catalase positive. The mnemonic is capillase. Capillase, C for candida. You have aspergillus. You have staphylococcus. You have serratia, nocardia. Right? These are basically your catalase positive chronic granulomatous disease. Chronic granulomatous disease. What is the defect here? The defect is in the respiratory burst, that is NADPH oxidase. Respiratory burst defect is what we have here. So remember, NADPH oxidase defect is what we have here. Next one, what is that? Immunodeficiency disorder, where along with the immunodeficiency, the infections, there also will be the history of oculocutaneous albinism. There also is the history of oculocutaneous albinism plus neuropathy plus thrombocytopenia can be there. That is Shediac-Higashi syndrome. Okay, what syndrome is that? That is Shediac-Higashi syndrome, where you have this defect. What do you have in Shediac-Higashi? Remember, Higashi is HIG, that is high granules are present. There are large granules which are present in the WBCs. What are these granules because of? Because of the defect in lysosomal trafficking, LYST gene which is affected. So Shediac-Higashi syndrome, there is defect in lysosomal trafficking, LYST gene. So all the cells basically which have granules wala, they are affected. So melanocytes are affected. The nerve cells are affected. So that is what you will see in Shediac-Higashi. Very, very important LYST defect. Going to the last topic for the day, that is lung cancer ke important points. For where do you see keratin pearls P40 and P63? Keratin pearls P40, P63. This is seen in squamous cell carcinoma. Okay, based on the markers, you should be able to identify that this is squamous cell. So remember that keratin. Where is the keratin present? Keratinized, stratified squamous epithelium. Right, so this is squamous cell carcinoma. Keratin pearls jahan pe honge, remember वहाँ marker is PP. Napsin A TTF1. Napsin A TTF1. This is with adenocarcinoma. Okay, this is with adenocarcinoma. So remember, adenocarcinoma is napsin A. A is the first alphabet. So that is TTF1. Okay, that is TTF1. So remember, this is adenocarcinoma. Neuron specific enolase, chromogranin, synaptophysin. So related to the neuron, related to the synapse, chromogranin. all of this is small cell carcinoma, which is basically under your neuroendocrine. So जो neuro वाले होंगे, that will come under small cell carcinoma. Okay, that will come under small cell carcinoma. Calretinin is a marker for mesothelioma. Okay, calretinin is a marker for mesothelioma. So mesothelioma is a tumor associated with which occupational lung disease? It is associated with asbestosis. Okay, it's associated with asbestosis. And remember, in asbestosis, what is the most common radiological finding? It is calcified pleural plaques. Okay, remember that it is calcified pleural plaques. So remember, calcified is calretinin. Okay, calcified pleural plaques, calretinin, they go together, seen in asbestosis, mesothelioma. Okay, mesothelioma. And what is this image showing here? This image, what is this image showing here? This is showing the keratin pearls. Okay, this is showing the keratin pearls which are seen in squamous cell carcinoma. Okay, squamous cell carcinoma. So these are the important markers that you should know for lung cancer. Okay, very, very important. So we have discussed quite a few topics today, right? So the first one we discussed was vasculitis, then we discussed the nephritic, nephrotic, infective endocarditis, amyloidosis, then you have immunodeficiency, and then you have lung cancer. So 6 topics is what we have discussed today. Extremely high yield, right? The rest of them basically also an update about the students who want to join this Sure Shot 150, where in 3 days it's happening in Delhi on 10, 11, 12 July. So basically Delhi में हो रहा है, ठीक है, और दूसरा 10, 11, 12 July, this is happening in Gautam Nagar itself. So very, very convenient for all the FMG students, and trust me that if you attend these 3 days classes, whatever you read, you revise and you do the PYQs, you can score that 150. Very, very important. So you have the last chance basically to enroll for the same. The link is given in the description of this video. So whoever is in Delhi, or you know anybody who's in Delhi and appearing for the upcoming FMG exam, also the NEET PG students and the final MBBS students appearing for next mock on 28 July should be attending these classes, because this will give you an extra edge and a kickstart to your preparation. You learn a lot of important topics, right? So this was for today, guys. We'll have the rest of the topics, not all of them of course, but a few of the rest of the topics also we'll be discussing in the upcoming sessions. But that will take some time, because like I said, I'll be having classes in Delhi. So for the next 4-5 days, I'll be occupied there. After that, we'll get back to our sessions. Okay. Thank you so much everyone for joining in. I hope you have enjoyed this session and got to learn a lot of important points here. And Neha, about the new platform launch, again that will be happening once I get some time to work on it. So maybe towards July end or August is when that will be happening. Okay, I'll update you on the Telegram group about the same. So thank you so much everyone for joining in, and goodbye. Take care and keep studying.